Our first talk is Diversity in Time in Range by Professor A.H. Aamir. Professor A.H. Aamir is a very renowned endocrinologist and diabetologist. He's among the pioneers of endocrinology in KPK, and currently he's head of endocrinology at Hayatabad Medical Complex, Peshawar. Please welcome Professor A.H. Aamir.
Straight away, it's the last session. Nobody wants to go from here, do you? Particularly people from Karachi. The weather is so good, but you've got to go. So I'll try to start and try to finish in time. My time was 45, but I assume that now it is 30 minutes, and I'll try to finish within time. This is the topic I'll be talking about, and these are my disclosures. Before we go any further, has anybody, and there are a lot of fellows here, has anybody noticed that we do see day in and day out patients with a very decent A1C, yet they have lots of complications? And, just show of hands? Show of hands? Yes, we do. And vice versa. A very high A1C, yet you don't see many complications. You just wonder why that happens. And it wasn't clear, and it might be one of the reasons what I'll be discussing today is what we'll be talking about, time in range, and something which is beyond A1C, what we've been doing so far, monitoring glycemic variability and time in range I'll be talking about, and the targets in the clinical practice as to what should be your target if you are concentrating in time in range. When we talk about A1C, I think, back in late 80s and early 90s, I still remember very vividly when I was trained in UK that A1C was not even that common. Do you agree? And at that time, in the clinics, we used to see fasting blood glucose, maybe self-monitoring, the diary, and we used to make decisions right there. And now you look back and you said how we were making those decisions just based on a diary. And then sometimes you would question that diary as well, that people might have filled it up, and that was very common practice. People fill it up and you look at the fasting, that was fine, and you didn't know what to do. And then, you were stuck. And then came the era of A1C, which has been with us for a long time. And it has become a main glycemic metrics for many of us now. And this is something which you use to qualitate the diabetes care in our clinical practice. So much so that A1C has become now a diagnostic criteria as well. We have done a survey on A1C, so it's become a diagnostic criteria as well. And it has become a marker for the risk of complication and targets to modify the trials, and most of the trials will see the outcome based on A1C. And so much so that the FDA and the regulatory bodies now want A1C to be recorded for the outcome trials and a cardiovascular to be the outcome to be used for the patient care and for the research. So A1C has been with us for a while. And it will remain probably with us for a while. But let's talk about A1C. I'll be talking about the A1C of 8%. Now, this is a person with diabetes who has got self-monitoring, and these are the pre-meal levels, and these are the post-meal level. A1C 8%. Very common scenario, what we see. And then we've got the same A1C of another person, and if you look at the pre-meal levels, they're almost identical, but slightly some on a higher side. And if you look at a post-meal, they're pretty decent, but the A1C remains same. Here, the post-meal is slightly on a higher side. So it is very difficult to tell what is happening to this person and what will be the outcome to this person based just on A1C. And this is their continuous glucose monitoring. Now, any volunteer or a fellow can tell what this A1C of 8 shows in terms of the continuous glucose monitoring, and what does this A1C of a subject B shows. Anybody volunteer? Yes, please. Lot of variability, yeah, and lot of peaks and valleys, lots of hypos, I suppose, not many on the other side. So, so once you look at this and you realize that there is something going wrong here, and it's not one, it's not two, it's just multiple, and they are missed. But once you have this kind of a graph, you would realize that just the A1C is not the metrics to be looked at. You need to be more precise on what is happening. And I think that's the reason the outcome, and my first question was that you will see a decent A1C, yet a lot of complications, and a vice versa. And that's the reason that this is happening. So that brings us to CGM. What is continuous glucose monitoring? There are two types of continuous glucose monitoring. So one is the real time, what was shown there, which is you attach the sensor and you record real time. And you see the information of glucose trends, how it goes up and down, how much is the time in range, how much is above and below. And then now, lately, we have got an instant CGM, which is the Libre type, in which the current levels plus the retrospective data can be put in as well. They are I mean, one would argue that they are very good, and they have become now standard of care in the developed world. And I was talking to Maltese, he's not here today, but even in the Western world, they are standard of care, but the limitation is the use is not easy because they are expensive and not widely available. And there are limitations in acute situations. But it has got a benefit that it gives a time in range of glucose targets, glycemic excursions can be picked up, daily profiles can be picked up, both in real time and in ICHM. And then the pattern of the hypo and hyperglycemia can be picked up very easily. So it brings us to another term which is very commonly used, which is called is glucose variability. It's a measure of fluctuations of glucose or other related parameter of glucose homeostasis over a given interval of time. And the glucose variability can be divided into short-term and long-term glucose outcomes. The short-term would be with a day or between the day, the two different days. And then the long-term, and I will show you at the end of my presentation, the long-term determination of this glucose variability over time and period of A1C and fasting and postprandial can be attached to it. So these are the glucose variability graph, which we can say, and it is one of the important metrics that will tell us that how much positive or negative outcome it will show in the patients. Now, monitoring variability and time in range to avoid the negative consequences for our patients is a key importance. So there are two useful measures of glucose variability. One is the amplitude and the other is the time. So on the x-axis is the time and on the y-axis is the amplitude, how much high the amplitude goes and how long the person will remain in the hyper or time in range in the hyper or hypo state. So these are the two excursions which we will look at, amplitude and the time on the x-axis, depending on what target you set up for this patient. With the glucose variability comes another term, and for our fellows is the coefficient of variance. If you even look at the coefficient, even glucometers. Even on the glucometers, at the back, there will be a term called CV. And if you look closely, that would mean that how much variability in that glucometer is there. So coefficient of variance is being used in these instruments for purpose of CGM or the amplitude. We have the researchers have calculated coefficient of variance or magnitude of variability relative mean level, which is standard deviation. For a stable glycemic control, the CV, the figure of 36 equivalent or less than 36 has been considered a suitable target. And if this coefficient of variance is increasing more than this or 36, that is considered to be bad. And if it is less than that, that is considered to be beneficial for the patient. There are different situations. If you look at a person who's on a diet and lifestyle changes, on a not any anti-diabetic medication, the coefficient of variance, and they are controlled, the coefficient of variance will be low. And as you go along with the addition of drugs and insulin, the coefficient of variance will increase. The highest the coefficient of variance, the higher the chances of hypoglycemic events. And that is very pertinent for patients who are type 1 and the patients who are type 2 but are on insulin. So the time in range is a percentage of time over a 24-hour period when the glucose is within the target range, which may be set up by the clinician as what is the time that they would like for this patient, whether that is 70 to 180, whether that is 70 to 140, depending on what kind of patients you are dealing with. It's a pregnant lady, obviously the target will be pretty tough. If it's somebody with a age above 70 or thereabouts with the comorbids, obviously your range will be different. And this has been now incorporated into international clinical guidelines, and time in range has been now shown to be part of the management in terms of type 1 and type 2. So what is time in range? It refers to time spent in an individual's target glucose range. The percentage of time spent below, which is time below range. So there are terms TIR, time in range. There's a term called TBR, time below range. And then there's a term called TAR, time above range, which refer to hypos and hyper. Time in range may be used for appropriate endpoint as a measure of glycemic control. And there's an evidence that inverse correlation and risk of developing a micro and both macrovascular complications in a patient with diabetes is linked to time in range. So what is this time in range that we are talking about? Generally, it is said that 70% of any person's glucose should be in time in range, 70% over 24 hours. That would mean around more than 16 hours a day. So if your glucose is around 16 hours a day or more within a range, you will have a better outcome. And then they have also devised the hypoglycemia part, or time below range, less than 1 hour per day for less than 70, and a severe hypoglycemia less than 15 minutes. These are the targets which are set. And then for above, more than 250 or more than, about 1 hour, 1.1 hour a day. And if you've got a target above range for more than 180, that you're talking about less than 6 hours a day. So this is important, that this is generally accepted, that more than 70% of your time needed to be in time in range. What's important? Because a challenge for patient with diabetes and has a wide range of serious complication, and time spent out in range are continuous issues for people with both type 1 and type 2. And this was a study done by Monnier, what it shows is 56% of persons with type 1 diabetes were found to have excessive glucose variability. And that what you mean is that they were having more hypoglycemia. 19% of patients with type 2 receiving insulin were found to have excess glucose variability, and around 9 hours a day are spent outside the target range, both in hyper or hypoglycemia. And as a result of all this, what we are seeing is most of these complications, severe hypo, quality of life, somebody spoke yesterday about, and of course, increase in mortality and morbidity. Now, hypoglycemia is one of the things which whenever you're talking about diabetes management, something which you want to avoid because of the responses of patients as a result of hypoglycemia, because of the defensive mechanism. They will have increased caloric intake, avoid exercise because that's what it induce, both in type 1 and type 2, reduce the dose. So this is the patient response. And then it also obviously impacts the outcomes in terms of A1C levels, the fear of future hypoglycemia, and reduced treatment adherence in terms of the outcomes related to it. So what are the we know that most of the trials, I mean, even if you take UKPDS or DCCT, the outcomes are based on A1C, and what you say is that 1% reduction will bring this much benefit. 1% up will bring this. Now, for a time in range, we have got some numbers as well, and that is reassuring because this is each 10% drop in time in range is associated with increased risk of retinopathy, which is about 64% risk. And if you look at the microalbuminuria, each 10% drop will result into 40% increase in microalbuminuria. So now we've got a figures to the time in range that if you remain in time in range around 70% and each 10% will drop, will bring micro and macrovascular complications. So we've got for a kidney, we've got for the eyes, and we've got for a neuropathy as well. It will bring about 25% increase in the risk of peripheral neuropathy, and also increased risk of all-cause mortality, about 8%, and 10% drop in time in range is associated with increased cardiovascular risk and CV mortality in these patients. More time in range is associated with decreased risk of cardiovascular, microvascular, and severe hypoglycemic complication versus less TIR. And if you look, everything on the right is beneficial. So more time in range will be beneficial for the patient, as is evident. And the severe hypoglycemia, if you can avoid, and micro and macrovascular muscular complications, all are improved if you keep them in time in range. It's not only that, the person who uses this matrix for their control, they feel better. They feel positive outcomes. So the feel-good impression is there as well. And the personal therapeutic success with their diabetes, where A1C usually doesn't. Because here you are seeing real time, or for that flash, you're seeing a real time improvement. And A1C is usually at the end of the 3 or 4 months, and that usually doesn't have that much impact on the person's well-being generally. So overall, it can impact the quality of life, treatment, satisfaction, independent of A1C, both in type 1 and type 2 patients. So glycemic variability and time in range targets for your clinical practice, and this is for the fellows to remember, is glycemic variability should be less than 36%. Time in range need to be more than or equivalent to 70%, which is about 16.8 hours per day. And additional recommendation for time in range ranges for different level. Some targets to be tailored to patients' requirement, as you see many recommendations now talking about the comorbids, they talk about the patients with renal insufficiency, they talk about patients who are elderly. So same applies here. So diabetes, if you're type 1 and type 2, more than 70% time in range, the other numbers I've talked about earlier. Uh, Type 1 and type 2, older or high risk, more than 50% time in range is being suggested. Obviously, you want less hypoglycemia in those patients because they have additional risk. Type 1 diabetes with pregnancy, again more than 70%, but remember your targets are very tight in pregnancy, and that's what is depicted here. And similarly, the other numbers. For gestational DM and type 2 diabetes, pregnancy, there's no specific recommendation as we speak, but I'm sure they will come up as more and more people with diabetes and women with pregnancy, complicated, bad obstetric history are using now these metrics for the control of diabetes and a better outcomes obstetrically. And we have been using this, and I'm going to show you a case or two. So people with type 1 diabetes, risk of is increased with each 10% drop was associated with increased frequency of retinopathy, microalbuminuria, increased risk of peripheral neuropathy. The numbers are pretty big. And the more you are out of range, the more you'll have a problem. And this is why A1C, the discordance of A1C and the complication usually doesn't seen in the clinical practice is evident now that what is the reason, and that is now the time in range. The mortality generally improves or otherwise if you're not in control, and the risk of severe hypoglycemia is decreased by 46% if you remain in time and range, and this is what we think the equation will be, that yes, we will continue to use A1C. I think it will remain with us for at least foreseeable time, if not all the time, simply because the CGMs, the flash monitoring, they are still expensive. And until the, shall I say, Chinese brand come in, which will be lower price, I think we will continue to use this. But if you have a reduced glycemic variability added to A1C, you will have a better outcome for your patient. For the interest, I've put real life cases. This is a 20-year-old lady with A1C of 6.9. And looking at his 6.9, she had a bad obstetric history and she wanted to conceive. And we said, well, we'll put you on CGM. You've got a decent A1C. When we put the CGM on her, look at the variation of A1C. This is all over the place. And we didn't even put the target down as yet. And this was, put at the target, because when you set the target too low, the CGM keeps bleeping. And that becomes difficult, but they have to turn it off, and it becomes very difficult. So these were the different numbers that she was getting. So time above range, look at the numbers and look at the A1C, 6.9. Yet we are seeing patients having a very high time above range. And ultimately, the graph settled down and it became in the range what we wanted for her. This is another male, 7.8 A1C. He had comorbids, and I was wondering that this is pretty decent, 7.8, 7.5 for a 65, 70-year-old with the comorbids. Okay. When we put a CGM on him, look at the graph. Where was it going? All over the place. And we tried to narrow the graph and brought it down at a level so that we can flatten out the glucose excursion and lesser glucose excursion. He was 7.8. Without giving any additional hypos, he came to 6.9 later on. And this is another, she was actually a doctor with an A1C of 7.6, wanted to conceive. We had this CGM attached to her. And look at and she's a doctor herself, and look at the variability which she's getting, a very high variability, the numbers going very high, and ultimately with the with this little tweak, we brought it to a flat line for her. This is now standard of care, at least for American Diabetes Association, and that's been published pretty recently. And as they suggest that real-time glucose monitoring for a time in range, the evidence is high, and intermittent scan continuous glucose monitoring, the evidence is slightly lower, should be offered to diabetes managers with adults with diabetes and multiple daily injections or continuous subcutaneous injections. Use has been extended to pregnant, hypo-unawareness, and selected type 2 diabetic patient. But I think this will change as the price will come down. This will change tremendously. I really believe that. And that's because the outcome, the positive impact on the patient personal life and well-being is so much once they use this time and range using the CGM, that the personal satisfaction patient gets is tremendous. So will time and range concept replace A1C? I don't know, but time will tell. I thank you very much for your patient listening.